All right, let's dive into something truly fundamental today. A part of our bodies we interact with countless times daily, often without a second thought, yet it's incredibly complex and absolutely vital for our most precious sense, sight. We're talking about your eyelids.
They really are remarkable structures, aren't they?
Yeah.
Far more than just, simple coverings. They're essential for protecting the eye, maintaining a healthy ocular surface, and even playing a role in the clarity of our vision.
And you've shared an extensive collection of material with us, excerpts from a medical text that goes incredibly deep into eyelid anatomy and the conditions that can affect them. Our goal in this deep dive isn't just to skim the surface, it's to unpack everything in these sources, helping you see the interconnectedness and the crucial details so you can gain a level of understanding that feels like, well, true mastery of this specific information, much like the professionals who live and breathe this field.
Right.
Everything we discuss is drawn directly from the pages you've provided.
It's about getting into the nuance, understanding why a particular structure is important, and how that relates directly to how things go wrong and how they're treated.
So, where better to start than right at the beginning? The sources lay out the fundamental building blocks of the eyelid.
Exactly. Think of it in layers. On the outside, you have the skin notably thin, very loosely attached, and different from skin elsewhere because it lacks fat in that deeper layer.
Okay.
Then on the inside, the part that touches the eyeball is the palpebral conjunctiva, a specialized mucous membrane.
And packed in between those two layers is where the real complexity lies. Muscles, glands, blood vessels, nerves, and dense connective tissue.
Yes, and that connective tissue isn't just random filler. It forms a critical structure called the tarsus. It's described as a stiff plate composed of dense fibrous tissue.
A plate. Quick.
And it's explicitly mentioned not to be cartilage, which is important because it speaks to its specific properties and how it behaves, especially when affected by, say, disease or age.
That structural plate gives the lid its shape and rigidity, right? Now, the sources really zoom in on the specific details within these layers. The skin has fine hairs and small sebaceous and sweat glands, but things get fascinating right at the edge.
At the lash margin, you have the cilia, the eyelashes themselves described as strong, short, curved hairs, typically arranged in two or more rows. And the glands here are quite specialized modifications.
They're not just typical sebaceous or sweat glands. The sebaceous ones become larger Zeiss glands associated directly with the lash follicles.
Right.
And the sweat glands near the margin, called Moll glands, are unusually large, and their ducts don't open onto the skin like normal sweat glands. They empty into the Zeiss gland ducts or the lash follicles.
It shows how interconnected everything is, even at that microscopic level right where the lash emerges. Then, moving slightly back, there's the free edge of the lid, often called the intermarginal strip. It's covered in stratified squamous epithelium, marking the transition from skin to conjunctiva.
This strip has a rounded anterior border and a sharp posterior border. The source highlights that sharp posterior border as clinically crucial. Why is that sharp edge so important?
Its angle of contact with the globe is absolutely vital for the capillary action that spreads the tear film properly across the eye surface. If that edge gets rounded or distorted, maybe through scarring or inflammation, it impairs the tear film distribution, leading to problems like tearing, epiphora.
So a tiny anatomical detail has a major functional consequence. Just anterior to that sharp posterior edge are the tiny openings of the meibomian glands, visible as a single row of minute orifices.
Exactly.
The source also points out a fine gray line between these openings and the anterior border, which serves as a crucial surgical landmark, indicating the plane between the orbicularis muscle and the tarsus, a plane of loose fibrous tissue.
Precisely. Knowing that gray line is there and what it represents is key for procedures like lid-splitting surgery. Embedded within the tarsal plate are the meibomian glands themselves. These are essentially highly developed, modified sebaceous glands.
They're described as straight vertical tubes, quite numerous, 20 to 30 in each lid, with their ducts opening onto that row of orifices we just saw on the lid margin.
Yeah.
These glands produce the oily layer of the tear film, which prevents evaporation.
Yes, the lid margin is a complex hub of activity and function. Then you have the muscles controlling the lid. The orbicularis palpebrarum is the primary muscle for closing the eye, lying between the tarsus and the skin.
And the main muscle for lifting the upper lid is the levator palpebrae superioris. The source describes its insertion points. The central part goes to the tarsus, a slip extends to the skin to create the lid crease.
That fold we all see.
Right, and a posterior slip goes to the conjunctiva and fornix.
It also mentions the superior transverse ligament, or Whitnall ligament, as a fibrous condensation of the levator tendon, marking where the muscle transitions into its flat aponeurosis. In the lower lid, fibers from the inferior rectus and inferior oblique muscles contribute to lower lid movement, attaching to the tarsus and palpebral ligaments via the capsulopalpebral fascia.
And there are also smooth muscles under sympathetic nervous system control. Miller's muscle in the upper lid originates from the levator and inserts into the upper edge of the tarsus. The inferior tarsal muscle in the lower lid is posterior to the capsulopalpebral fascia and inserts into the lower tarsus.
Their sympathetic innervation is why your eyes might widen slightly when you're surprised or scared. The sympathetic system is activated, causing these muscles to contract just a bit.
Ah, interesting.
The sources also cover the blood supply. Arterial arcades forming networks. In the upper lid, there are both peripheral and marginal arcades. In the lower lid, mainly marginal, the peripheral is less developed.
Venous drainage involves post-tarsal plexuses draining into the ophthalmic veins and pre-tarsal plexuses draining into subcutaneous veins. And the lymphatic drainage pathways are quite specific, divided geographically.
Yeah, that's important for infection spread.
Right. The medial third of the upper lid and two-thirds of the lower drain to the submandibular nodes, while the lateral two-thirds of the upper and one-third of the lower go to the pericular nodes.
Understanding those lymphatic pathways is crucial for predicting potential spread of infection or malignancy, a point we'll definitely touch on later. Finally, the nerve supply. Sensory input comes from the trigeminal nerve,
Right.
specifically the ophthalmic division for the upper lid and maxillary for the lower. Motor control for the levator is from the third cranial nerve, and for the orbicularis, it's the seventh cranial nerve. And, as mentioned, sympathetic fibers supply Mueller's muscle and the inferior tarsal muscle.
So, wow, it's not just skin and muscle. It's a sophisticated arrangement of layers, specialized glands, precise nerve control, and targeted blood lymph supply, all packed into something that weighs almost nothing.
Exactly.
This anatomy is absolutely foundational, as the source emphasizes, for understanding everything else that follows. Knowing about that sharp posterior border, the location of the meibomian gland openings, the different muscles and how they're innervated, these aren't just academic points. They explain why things function as they do and what goes wrong when they don't.
Absolutely. And often the first visible sign that something is amiss is swelling, or edema.
The sources describe this as a common issue. Due to the loose nature of the eyelid tissue, swelling can be quite dramatic, sometimes even preventing the eye from opening. They outline two main types: inflammatory and passive.
Inflammatory edema is triggered by, well, inflammation, as the name suggests. This can be a local issue like dermatitis, a sty, or an insect bite right on the lid. But it can also be secondary to inflammation spreading from nearby structures, the conjunctiva,
Okay.
often resulting in chemosis, that glassy swelling of the eye surface membrane,
Right, I've seen that.
the lacrimal sac, or even purulent infections in the eye itself, the tissue behind the eye, Tennant's capsule, the orbit, or nasal sinuses. A fascinating detail is that chronic thickening, sometimes called solid edema, can be a long-term consequence of recurrent erysipelas, a specific bacterial skin infection.
And passive edema is different. It's due to circulatory issues, a problem with blood or lymph flow.
This can be part of a general systemic condition like kidney or heart failure, affecting fluid balance throughout the body. Or it can be a local obstruction, like a dangerous condition called cavernous sinus thrombosis, affecting blood drainage from the head.
Serious stuff.
Yeah. The source also mentions acute, sudden, and often recurrent swelling called angineurotic edema, which is part of a generalized allergic reaction or anaphylaxis.
So eyelid swelling is a symptom that can point to a variety of underlying causes, from a simple bug bite to serious systemic illness.
Exactly. Moving beyond just swelling, the eyelids are prone to inflammation generally.
Like dermatitis, similar to how skin anywhere else can get inflamed, but particularly common here due to the thin, sensitive nature of the skin. Allergic dermatitis is a frequent culprit, often triggered by things we apply near the eyes: cosmetics, hair dyes, or even medications like atropine drops.
Right. Eczema can also occur, especially if there's associated tearing or discharge from the conjunctiva.
Yeah.
Standard bacterial infections like Staphylococcus or Streptococcus can cause localized issues like boils or abscesses. Specific infections like anthrax or herpes zoster can also affect the lids.
And erysipelas is highlighted as a particularly concerning.
Yes, because of its potential to spread rapidly and deeply, potentially leading to serious complications like orbital cellulitis, that dangerous cavernous sinus thrombosis we mentioned, or even meningitis.
That really emphasizes that even a seemingly simple skin infection on the eyelid needs careful attention. Now, a large portion of the source material focuses on a very common and often chronic issue, blepharitis.
Yes, blepharitis is chronic inflammation specifically of the eyelid margins. It can range from simple redness to significant inflammation with crusting and changes to the lid structure. The sources break it down into two main types, anterior and posterior.
Anterior blepharitis involves the area around the base of the lashes. It has two subtypes.
First, seborrheic or squamous blepharitis. This is characterized by scales along the lash bases. Squamous scales are typically white and flaky, like dandruff, and fall off easily. Seborrheic scales are yellowish and stickier. Okay. Removing these scales reveals a red, inflamed surface underneath. This form often occurs alongside similar conditions on the scalp. The sources suggest addressing the underlying cause, daily cleaning of the lid margins, perhaps with a dilute baby shampoo solution, and treating any secondary infections.
The second type, staphylococcal or ulcerative blepharitis, sounds more serious because it's directly infective, most commonly caused by Staphylococcus bacteria.
It is, generally. Here you see hard yellow crusts or dry scales that effectively glue the lashes together. When you remove these crusts, you find small ulcers around the base of the lashes that bleed easily. Symptoms include noticeable redness, itching, soreness, excessive tearing, and sensitivity to light, photophobia.
How do you differentiate this from conjunctivitis if both can cause crusting?
The source gives a key distinction. With staphylococcal blepharitis, removing the crusts reveals that the lid margin itself is ulcerated or inflamed. In conjunctivitis, the discharge glues the lashes, but the lid margin underneath is typically normal.
Okay, that's a very useful clinical sign. For treating ulcerative blepharitis, the sources really stress energetic local treatment.
They do. This involves daily cleaning to remove the crusts, again, often using a dilute solution like baby shampoo. Loose, infected lashes associated with ulcers should be epilated, pulled out.
Right.
Once the crusts are removed, antibiotic ointment is applied to the anterior margin.
Mm.
Ideally, this is based on testing the bacteria's sensitivity to different antibiotics.
And for long-term prevention after the acute infection clears.
It becomes about routine hygiene, daily swabbing of the lid margins with a warm, bland solution, and crucially, avoiding rubbing or touching the eyes with unwashed hands to prevent reinfection. The sources note that recovery is generally speedy with proper treatment.
But if it's not treated properly or is chronic, there can be significant long-term consequences.
Absolutely. The ulcerative form, in particular, can lead to chronicity and often causes or exacerbates chronic conjunctivitis. More seriously, deep ulceration can destroy the hair follicles, leading either to permanent lash loss,
Called metarosis.
matarosis, yes,
Yeah.
or perhaps worse, distorted lash growth, called trichiasis, where they grow inwards towards the eye.
So the scarring from the ulcers can actually deform the lid margin.
Exactly. As the ulcers heal, the resulting scar tissue contracts. This pulls nearby hair follicles, causing misdirected lashes that rub against the cornea. In severe prolonged cases, the excessive scar tissue can cause the lid edge to thicken and even droop under its own weight, a condition called tylosis. The source highlights that the lower lid is particularly prone to displacement from this scar contraction.
And when the scar tissue contracts, it pulls the conjunctiva over the margin, rounding off that crucial sharp posterior intermarginal strip we discussed earlier.
Which then impairs the tear film distribution and capillary action.
Back to that sharp edge.
Exactly. Leads to tearing that spills over the lid margin epiphora. This tearing is made worse if the punctum, the small opening that drains tears, also everts and loses contact with the eyeball.
Right.
The constant wetting of the skin by tears causes eczema, which in turn leads to more skin contraction, potentially causing ectropion, the outward turning of the lid, which then makes the tearing even worse, creating a frustrating vicious circle.
Wow. That's a powerful example of how one seemingly small problem can cascade into multiple interconnected issues affecting the entire ocular surface. What about posterior blepharitis?
Posterior blepharitis focuses on the meibomian glands and their function. It's strongly linked to instability of the tear film and can cause inflammation of the cornea's lower surface, inferior punctate keratitis.
How does it present differently from anterior blepharitis?
There are two main patterns described. One is meibomian seborrhea, essentially just excessive oil production.
Yeah.
You might see visible oil droplets at the gland openings, and sometimes a phony secretion can be expressed. The other is meibomianitis, which involves diffuse thickening and rounding of the posterior lid margin with inflammation around the gland openings. With lid massage, you can express thick, toothpaste-like material from the glands. If the ducts become blocked, cysts can also form within the glands.
And treatment for posterior blepharitis seems different from the anterior type.
Yeah, the mainstays are warm compresses and lid massage to help express the thick secretions. Often this is combined with a course of oral antibiotics, usually from the tetracycline class like doxycycline or minocycline, taken for several weeks, typically around 6 weeks as mentioned in the sources.
Beyond blepharitis, the sources mention other types of inflammation affecting the lids. Molluscum contagiosum, for instance.
This is caused by a pox virus and appears as small, white, often multiple swellings, typically on the lid margin, with a characteristic central indentation, umbilication. You can express a cheesy material from them. Under the microscope, they contain large inclusion bodies.
And why is this seemingly small skin lesion so important in an eye context?
Because it can cause a severe, persistent conjunctivitis and sometimes even inflammation of the cornea keratitis that won't get better until the primary molluscum nodules on the eyelid are treated.
Really?
Yeah. The treatment involves incising and expressing the contents and then cauterizing the interior of the lesion with something like tincture of iodine or pure carbolic acid. It's a classic example of how a seemingly minor external issue can cause major internal eye problems if the source isn't addressed.
That's a crucial takeaway. Another inflammatory condition discussed is preseptal cellulitis.
This is a bacterial infection of the eyelid tissue, specifically anterior to the orbital septum, that fibrous barrier behind the lids that separates them from the deeper orbital structures.
Ah, the septum.
Right. It's usually caused by trauma or infection spreading from nearby areas like the sinuses. Symptoms include acute pain, swelling, redness, increased local temperature, and tenderness of the eyelid.
And the key point of differentiation from the more dangerous orbital cellulitis.
With preseptal cellulitis, vision is normal, eye movements are normal, and there is no proptosis.
Proptosis being the eye bulging forward.
Exactly. Orbital cellulitis, being deeper, affects structures within the orbit and will cause visual changes, reduced eye movement, and proptosis.
So, maintaining normal vision and eye movement is the critical sign that the infection is still confined to the anterior part of the lid.
Exactly. But the danger is that preseptal cellulitis can spread posteriorly into the orbit, leading to vision loss, proptosis, and potentially meningitis. So prompt treatment is essential. It involves broad-spectrum oral antibiotics, such as amoxicillin and NSAIDs, to help with inflammation and pain.
Okay, let's focus specifically on acute infections originating within the eyelid glands themselves, like the common stye or hordeolum externum.
Right. The sources describe this as a pus-forming inflammation of a Zeiss gland, one of those modified sebaceous glands near the lash base.
Okay.
It typically presents as a swollen, hard, painful lump on the lid edge. The entire lid margin might be swollen around it. An abscess forms, usually coming to a head near the base of an eyelash. The pain is quite significant until the pus is released. Yeah. Styes often occur in crops and can be associated with issues like boils or acne elsewhere. They're very common in young adults, but can happen at any age, particularly in people who are run down or debilitated.
Treatment involves oral antibiotics and applying hot compresses. The abscess can often be drained by gently pulling the affected eyelash or making a small incision. Oral antibiotics are needed if the infection starts to spread, causing preseptal cellulitis.
For people who get recurrent styes, the sources suggest investigating potential underlying issues like diabetes, ensuring they aren't excessively rubbing their eyes, checking for uncorrected vision problems, refractive errors that might cause rubbing, and sometimes a course of oral antibiotics like tetracycline might be considered to break the cycle.
And then there's the hordeolum internum.
This is a pus-forming inflammation of a meibomian gland. It's less common than an external stye, but often causes more severe symptoms because the meibomian glands are larger and embedded deep within the dense fibrous tarsus.
Right, inside that plate.
Exactly. The pus usually becomes visible as a yellowish area when you avert the eyelid, visible through the conjunctiva. It typically bursts either through the duct opening on the lid margin or through the conjunctiva itself, though rarely through the skin. Treatment principles are similar to an external stye, but if incision is needed, the approach is more like draining a chelation.
Which brings us to chalazione. The sources are quite specific about this. It's emphatically not a true cyst, even though it's often called a tarsal or meibomian cyst. It's described as a chronic inflammatory granuloma of a meibomian gland.
That distinction is key to understanding its nature. Chalasia are frequently multiple, can occur in crops, and are more common in adults. The normal gland tissue is replaced by chronic granulation tissue, a mix of inflammatory cells like giant cells, plasma cells, histiocytes, and polymorphs. This process is thought to be triggered by chronic irritation from retained meibomian gland secretions.
Clinically, you usually notice a hard, painless swelling in the eyelid that grows gradually. Initially, there aren't typical signs of acute inflammation like redness and pain.
Right, it's often just a lump.
Smaller ones might be felt before they're easily seen. When you avert the lid, the conjunctiva over the chalazion is typically red or purple initially, becoming gray later, or yellowish if it gets secondarily infected. The gray appearance is due to the granulation tissue turning into a jelly-like mass.
Spontaneous resolution can happen, but is often incomplete. Sometimes, the contents might extrude through the conjunctiva, particularly in marginal chalasia, forming a small, irritating fungating mass of granulation tissue on the lid margin.
Treatment options range from conservative to surgical.
For smaller chalasia, an injection of a steroid like triamcinolone acetonide directly into the lesion can help reduce the inflammation and aid resolution. If that doesn't work, or for larger chalasia, surgical incision and curettage, basically scraping out the contents, is the standard treatment.
The source provides a detailed description of the surgical technique.
Yes, it's done under local anesthesia, using injections around the lesion and topical drops. A chalasian clamp is used to avert the lid and provide a bloodless surgical field. A vertical incision is made on the inner surface of the lid through the conjunctiva, directly over the lump, being careful to avoid cutting into nearby healthy glands.
Okay.
The semifluid contents are drained, and then the walls of the cavity are thoroughly scraped with a curette to remove all the granulation tissue. For long-standing chalasia that develop a pseudocapsule, this needs to be removed as well.
After releasing the clamp and applying pressure, the source notes that swelling will remain for a while due to blood filling the cavity, and the patient should be warned about this.
Yeah, that's important expectation management. If the curettage isn't complete, granulation tissue can sprout afterwards, requiring rescraping. Very hard chalasia, especially those near the corners of the eye, might actually be something different, like benign tumors called adenomata, and might require a more formal excision.
And a critical point mentioned is malignancy risk.
Yes, while malignant changes are rare, any chalazion that keeps coming back in the same spot or appears in an elderly person should raise suspicion and be biopsied to rule out a sebaceous cell carcinoma, that gland cancer we mentioned earlier. This again underscores the importance of understanding the underlying pathology.
Absolutely. It's never just a lump. It could be one of many things. Now let's shift focus to anomalies in position when the eyelashes or the entire eyelid itself isn't sitting where it should be.
A striking example is blepharospasm, which is involuntary, sustained, and often forceful closure of the eyelids.
The sources distinguish between essential and reflex sensory blepharospasm. Essential blepharospasm is spontaneous, typically starting in middle age, 45-65, with brief, involuntary eyelid closures and difficulty opening the eyes. It can be less noticeable when the person is focused or distracted.
Treatment for essential blepharospasm often involves medical options like botulinum toxin injections, Botox. The source details typical dosage distribution across various facial muscles involved in blinking. They note that relief usually lasts for several months, around 10.5 weeks on average.
Wow. Quite specific.
Yeah. Surgical options include selectively weakening or removing parts of the muscles involved, or avulsing branches of the facial nerve.
Reflex or sensory blepharospasm is different. It's triggered by external stimuli.
Yes. Things like bright light, irritation on the surface of the eye, or even irritation on the eyelid itself can precipitate the spasm. Symptoms include sensitivity to light, photophobia, a feeling of discomfort, or a foreign body sensation. The treatment here is logical. Identify and remove the offending sensory stimulus.
Another positional issue is trichisis, where the eyelashes are misdirected and rub against the surface of the cornea.
This is a significant problem because those misdirected lashes constantly irritate the eye. The most common causes are conditions that scar the eyelid margin or lead to entropion.
Which we'll get to.
Yes. Trachoma, a serious infectious eye disease, is a major global cause. Other causes include spastic entropion, chronic blepharitis, autoimmune conditions like pemphigoid, and scarring from trauma, burns, surgery, or severe reactions like Stevens-Johnson syndrome. It can involve just a few lashes or be widespread.
And congenital causes, too.
Right, the sources also mention congenital dystichiasis, a condition where a whole extra row of lashes grows from an abnormal location.
Symptoms are what you'd expect: foreign body sensation, constant irritation and pain, redness of the conjunctiva, reflex blinking spasms, and tearing. And the consequences can be severe.
They can. Chronic rubbing can cause recurrent abrasions on the cornea, leading to scarring, opacities, blood vessel growth into the cornea, vascularization, and recurrent ulcers that can severely threaten vision. A misdirected lash, rubbing an ulcer can even prevent it from healing.
So treatment aims to stop the lash from rubbing.
Exactly. For just a few isolated lashes, epilation, plucking them out, can provide temporary relief, but they usually regrow within a few weeks. A more permanent solution is needed, destroying the hair follicle. The sources detail several methods: diathermy, electrolysis, cryosurgery, and argon laser.
They give specific parameters for some of these, like using a fine needle at 30 MA for 10 seconds with diathermy, or using specific poles and current with electrolysis. They note electrolysis can be painful but manageable with local anesthesia.
Right, and you look for a foamy discharge at the follicle opening and easy lash removal as signs of success. For cryotherapy, the source describes splitting the lid margin at the gray line to expose the follicle roots, then applying a cryoprobe using a double freeze-thaw cycle to a temperature of -20 degrees C.
That sounds intense.
It is. This is indicated for larger groups of lashes but carries risks like tissue death, necrosis, and loss of pigmentation. For localized groups, surgical excision techniques or laser can be used. If many lashes are involved due to a deformed lid margin, then the underlying problem of entropion needs to be corrected.
Which leads us directly to entropion, the inward rolling of the entire eyelid margin, causing the lashes and that sharp posterior border to rub against the cornea.
This is very damaging to the tear film and the health of the corneal surface. The basic issue is an imbalance or disparity between the anterior layer of the eyelid, skin and muscle, and the posterior layer, the tarsus and conjunctiva. Management depends entirely on the specific cause.
The sources classify entropion into four main types: involutional, cicatricial, spastic, and congenital. Symptoms are primarily tear film instability and the secondary trichiasis caused by the lashes rubbing the eye.
Involutional entropion is age-related, the most common type. The pathogenesis is multifactorial, related to general laxity that occurs with aging, weakening or detachment of the inferior retractors.
The things that pull the lid down.
Yes, those structures. Also, laxity of the canthal ligaments that anchor the lids at the corners, loss of orbital fat leading to the eye sinking back slightly in ophthalmos, and the orbicularis muscle overriding and pushing the pretarsal part forward, causing the tarsus to rotate inwards.
So the age-related changes collectively cause the lid to lose its tautness and stability, allowing it to roll inwards. Surgery aims to address these specific issues.
Yes, it involves reattaching the retractors to the tarsus, tightening horizontal laxity, and sometimes creating scar tissue between parts of the orbicularis muscle to prevent it from overriding. The source mentions temporary treatments for patients who aren't fit for surgery, like using specific averting sutures.
Right.
Placed from the conjunctiva to the skin, tied firmly, to temporarily avert the lid and create scar tissue that acts as a barrier.
For significant horizontal laxity, specific surgical techniques are described that involve removing excess tissue near the outer corner of the eye and using sutures to fix the tarsus and orbicularis to the lateral canthal structures.
And in more severe cases, particularly in the lower lid, procedures involve surgically shortening and reattaching the inferior lid retractors to the tarsus, often requiring careful dissection to expose the tarsus and the space behind the orbital septum. The goal is to restore the downward movement of the lid when looking down.
Cicatricial entropion is caused by scarring and contraction of the conjunctiva lining the inner eyelid, which shortens the posterior layer and pulls the margin inwards. It's especially severe in trachoma, where the tarsus itself can become bent and distorted.
Other causes include trauma, burns, autoimmune conditions like Stevens-Johnson syndrome, and ocular cicatricial pemphigoid. Treatment involves plastic surgical procedures to lengthen the posterior layer and rotate the tarsus outwards. The source notes that while local anesthesia is used, cutting the tarsus can still be uncomfortable.
For milder cases with a thickened tarsus, techniques involve removing a wedge-shaped piece of tarsus.
Right, a wedge resection. For more severe cases or thin tarsus, a tarsal fracture or horizontal incision through the tarsus is made, and then sutures are used to bend the lid margin outwards. Extensive scarring might require replacing the conjunctiva with grafts, such as from the inside of the mouth, buccal mucous membrane, or replacing distorted tarsus with cartilage grafts.
Spastic entropion is a temporary response to significant irritation or trauma, often seen in elderly individuals. It's due to spasm of the orbicularis muscle combined with age-related changes in connective tissue.
It involves the orbicularis muscle riding up over the tarsus and rolling it inwards, often seen alongside existing horizontal laxity. It can be triggered by things like tight bandaging or even narrow palpebral apertures. It almost always affects the lower lid.
Treatment sounds logical.
Yeah, focuses on addressing the precipitating cause, example, lubricating eye drops, antibiotics for infection, removing a tight bandage, or using temporary measures like plaster to pull the lid away. If it persists, injections of botulinum toxin into the muscle can help relax the spasm. Surgical treatment aims to create a fibrous ridge to prevent that upward sliding of the orbicularis muscle, using sutures placed through the tarsus and skin.
And congenital entropion.
Rare, present from birth, typically due to underdeveloped lower lid retractors or an abnormality of the tarsus. Treatment targets the specific structural cause. The source mentions differentiating it from epophion, where a fold of skin, not the lid margin itself, pushes the lashes onto the eye.
All right, the opposite problem is ectropion, the outward turning or aversion of the lid margin and lashes away from the globe.
This is particularly problematic for the lower eyelid, which is essential for protecting the eye and acting as part of the lacrimal pump mechanism that drains tears. Like entropion, it can be acquired.
Due to age, scarring, paralysis.
Right, or mechanical factors, or it can be congenital. The most common acquired type is involutional ectropion, related to aging.
And the age-related changes here are relaxation of the structures that support the lid and the canthal ligaments, leading to the lid becoming horizontally longer and lax.
Exactly. Age and gravity cause the entire suspensory system of the lid to become lax. The source describes the progression. Mild, the punctum doesn't touch the eye when looking up. Moderate, the punctum isn't touching in primary straight-ahead gaze. And severe, the entire lid margin is turned away, exposing the conjunctiva and the fornix.
The fornix being the fold.
Yes, the folded conjunctiva. Weakness of the underlying tissues, like the capsulopalpebral fascia, also contributes.
And if the punctum isn't against the eye, it can't drain tears effectively.
Right. This leads to tearing epiphora. Chronic exposure can cause the conjunctiva to become dry, thickened, and inflamed. In severe, long-standing cases, the cornea itself can suffer from imperfect closure, leading to dryness and keratitis. The tear drainage opening can also narrow, punctophimosis, and even develop keratinization.
Diagnosis often involves physical tests, like the lid distraction test.
How far you can pull the lid away.
Right, and assessing how quickly it snaps back and how much the canthal ligaments can be displaced.
For mild cases of ectropion, conservative measures like artificial tears to keep the eye moist and advising the patient to wipe tears upwards and towards the nose can help, but often surgery is needed.
Surgical approaches for involutional ectropion aim to tighten the lax structures.
For mild to moderate ectropion, this might involve excising a spindle-shaped piece of conjunctiva horizontally and suturing it to help pull the lid back against the eye, particularly to reposition the punctum. If the ectropion is most prominent in the central part of the lid, a section of the full lid thickness might be removed and sutured.
For more severe ectropion, especially affecting the outer half of the lid.
Techniques involve creating a skin flap and shortening the lid horizontally at the lateral canthus, using specific suture techniques to pull the lid taut. If there's significant laxity of both the lid and the lateral canthal ligament, common modern techniques involve detaching the ligament, cantholysis, excising a portion of the lid thickness, and forming a strip of tarsus that is then reattached securely to the bone at the outer corner of the eye. For medial ectropion affecting the inner corner and punctum, a procedure called the modified lazy T operation involves removing specific wedge shapes of tissue to reposition the punctum, while carefully protecting the tear drainage channel, the canaliculus.
In cases of complete ectropion involving the entire lid, a combination of procedures is often necessary, including tightening the horizontal laxity and potentially reattaching the lower retractors. The source notes that using a CO2 laser can be advantageous in surgery as it provides a relatively bloodless field.
Paralytic ectropion is caused by weakness or paralysis of the orbicularis muscle, most commonly due to facial nerve paralysis, as seen in conditions like Bell's palsy or after trauma or surgery.
Initial treatment is often conservative, using tape to hold the lid up and artificial tears to protect the eye, hoping for nerve recovery. If the paralysis is permanent, surgery is needed.
A common procedure is lateral tarsorrhaphy, which surgically joins the upper and lower lids at the outer corner to shorten the palpebral aperture and provide better coverage. For long-standing paralysis with associated lid laxity, techniques similar to those for involutional ectropion, like shortening the lid and reattaching the lateral tarsal strip, might be used.
And if there's incomplete closure, too.
Right. If there's also leg ophthalmos or retraction of the upper lid, measures like taping the lids shut at night or surgically placing a small gold weight in the upper lid can help with closure.
Cicatricial ectropion is caused by sparring that shortens the anterior layer of the eyelid, skin and muscle, pulling the lid margin away from the eye. Causes include burns, trauma, or chronic skin inflammations.
Treatment focuses on releasing the scar tissue and lengthening the anterior layer, typically through plastic surgical procedures. For localized scars, techniques like Z-plasty or VY-plasty are used to rearrange tissue. For larger or more extensive scars, the scar tissue is excised, surrounding adhesions are released, and the resulting defect is covered with a skin graft or flap, often taken from areas like the upper lid, behind the ear, or inner upper arm.
And they use a suture to prevent contraction.
Yes, using a superior traction suture temporarily helps prevent the new graft from contracting early.
Next, symbolferrin adhesion of the eyelid to the eyeball itself.
This happens when raw surfaces of the conjunctiva on the eyelid and the conjunctiva covering the eyeball are in contact during healing and stick together. Severe chemical or heat burns are common causes, as are conditions like Stevens-Johnson syndrome, corneal ulcers, diphtheria, or complications from surgery. The adhesions can form fibrous bands, either narrow or broad, and can affect just the front parts of the lid globe or the deeper fornix, symbolferrin posterior. Total adhesion is rare.
What are the consequences? Sounds bad.
It is. Significant impairment of eye movement, which can cause double vision, diplopia. If the adhesion is extensive, it can prevent the eyelid from closing fully, leading to leg ophthalmos and severe exposure problems for the cornea. It's also disfiguring. Prevention is absolutely key here.
How is it prevented?
The source emphasizes early and frequent intervention, such as sweeping a glass rod along the fornix to break adhesions, or using a therapeutic bandage contact lens to keep the surfaces separated during healing. Once established, surgery is necessary to release the attachments, but it's challenging, especially with broad adhesions or those in the fornix.
And you have to cover the raw areas.
Absolutely. The raw areas left after release must be covered immediately with grafts, conjunctival grafts from elsewhere in the same eye, mucous membrane grafts from the mouth, or amniotic membrane. Preventing the adhesions from reforming is difficult and might require therapeutic contact lenses or special rings placed in the fornix.
Ankylobulferrin is related, involving adhesion of the lid margins to each other.
This could be congenital or acquired, often due to burns. It can be partial or complete, and is frequently seen alongside symbolferrin. Treatment depends on whether symbolferrin is also present and its extent. Surgery to separate the lid margins is often contraindicated if there's severe symbolferrin, as it would expose raw areas. If done, the lids are separated and kept apart during healing. If the adhesion extends to the corner angle, an epithelial graft is needed there to prevent it from sticking back together.
Blepharophimosis describes a palpebral fissure that appears smaller than normal.
This appearance can be acquired, often resulting from scarring contraction after chronic tearing or eyelid spasm, leading to a vertical skin fold near the outer corner of the eye, epicanthus lateralis, that hides the true outer angle. Or it can be congenital, simply congenital narrowing of the aperture. The acquired form may resolve once the underlying inflammation is treated, but sometimes canthoplasty surgery on the canthus is needed to widen the opening.
And finally, leg ophthalmos, which we've mentioned in the context of other conditions. It's the inability to close the palpebral aperture completely when attempting to shut the eyes.
This can be caused by direct lid problems like scarring contraction, congenital defects, ectropion, or paralysis of the orbicularis muscle. But it can also be due to the eyeball itself being pushed forward, proptosis, as seen in thyroid eye disease or orbital tumors, making the lids relatively too short to cover it.
Or just from illness.
Right. Or it can be due to general tissue laxity and reduced blinking in severely ill or unresponsive patients.
The consequences are serious for the cornea, which needs to be covered and kept moist.
Exactly. Incomplete closure leads to exposure, keratopathy, damage from drying, keratinization, the surface turning into a dry, skin-like tissue, and keratitis, inflammation of the cornea. Treatment focuses on protecting the cornea. For milder cases, this means frequent artificial tear substitutes. In severe cases, surgical tarsorrhaphy is performed.
And how is that done? Briefly.
The source describes freshening opposing areas of the intermarginal strip of the upper and lower lids and using sutures to make the lid edges adhere together, effectively narrowing the opening and covering the cornea.
That was a comprehensive look at how being out of position can profoundly impact eye health. Now, let's move to ptosis, the drooping of the upper eyelid.
Ptosis is specifically defined as the upper eyelid margin covering more than 2 millimeters of the superior cornea. It's more often unilateral in over 70% of cases. The causes are varied, often involving the main lifting muscle, the levator palpebrae superioris, either due to being underdeveloped or diseased, or issues with its nerve supply.
Genes are involved sometimes too.
Yes, associated genes have been identified for some types. Upper lid elevation is primarily the job of the levator, with help from the frontalis muscle, the forehead muscle, which you recruit when trying to open a droopy eye wider, and Mueller's muscle, and the source notes that spesis can be due to paralysis or simply defective development of the levator. There can also be mechanical ptosis, where the lid droops due to something adding weight or preventing it from lifting, like a tumor or the scarring from trachoma.
And the source also mentions pseudoptosis, which is apparent drooping, where the lid looks droopy, but the problem isn't actually with the levator muscle itself.
Right, this can happen if the eye is shrunken or absent, cissus bulbi and nothemos, meaning there's less support from below. Or if there's excess, heavy eyelid skin, dermatocallusis, weighing it down. Or even if the other eyelid is pulled too high, contralateral lid retraction, making the normal lid look comparatively low. It's crucial to rule these out.
Ptosis is classified into congenital, present from birth, and acquired.
Congenital ptosis can be simple, isolated, or complicated, associated with other eye movement disorders, or part of syndromes like blepharophimosis syndrome, or have unusual associated movements like Marcus-Gunn jaw-winking ptosis.
Jaw-wink.
Yeah, where the lid lifts when the jaw moves. Acquired ptosis is categorized by the underlying issue: neurogenic, nerve problem; myogenic, muscle problem; aponeurotic, problem with the levator tendon; or mechanical. It can affect one eye or both, be partial or complete.
The source mentions how to assess ptosis during examination. The normal upper lid position is roughly midway between the upper border of the pupil and the limbus.
The edge of the colored iris, yeah. Measurement is key. A simple diagram can help record findings. The amount of mitosis can be measured by comparing the width of the palpebral aperture between the two eyes in unilateral cases, or more precisely, using the margin reflex distance, MRD.
MRD1 and MRD2.
Right. MRD1 is the distance from the corneal light reflex, a point of light on the pupil, to the upper eyelid margin, measured in primary gaze while preventing the patient from using their forehead muscle. MRD2 is the distance from the reflex to the lower lid margin. The difference in the MRD1 from normal, around 4.0 millimeter, indicates the amount of ptosis.
Callahan and Beard's classification is mentioned. Mild ptosis is up to 2 millimeter, moderate is 3 millimeters, and severe is 4 millimeters or more. Severe ptosis is visually significant as it covers the pupil.
Definitely. The source notes compensatory mechanisms. Patients often wrinkle their forehead by overusing the frontalis muscle and adopt a chin-up posture to see better. That characteristic attitude with raised brows and forehead wrinkles is a telltale sign.
Okay.
Partial ptosis can sometimes be masked by this frontalis action, but you can reveal the true amount by gently holding the patient's eyebrows to prevent them from lifting. Assessing levator function is also critical. This is the amount the upper lid moves from looking straight down to looking straight up, again with the brow fixed. Good function is defined as 8 millimeters or more, fair is 5-7 millimeters, and poor is 4 millimeters or less.
In infants, there's a simple test mentioned. If you evert the upper lid, does it spontaneously return to normal position when the eye looks up? If it stays averted, it suggests significant levator weakness.
Right. For unilateral ptosis surgery, the goal is often to match the height and contour of the unoperated lid fold. So the source stresses carefully observing and recording the details of the normal lid fold before surgery. Another important preoperative assessment is Bell's phenomenon.
The upward eye roll on closing.
Yes. If Bell's phenomenon is poor, there's a higher risk of the cornea being exposed during sleep after ptosis surgery, potentially leading to serious damage. Corneal sensation should also be tested for similar reasons, and as we mentioned earlier, always check for causes of pseudoptosis.
Congenital ptosis is the most common type, usually due to defective muscle development. It's often bilateral and can run in families. Simple congenital aposis is isolated, while complicated types have other eye muscle abnormalities or are part of syndromes like blepharophimosis syndrome.
Which we mentioned earlier: ptosis, short fissure, epicanthus inversus telecanthus, lower lid ectropion.
Right. And those unusual synkineses like Marcus-Gunn jaw-winking ptosis. It's important to examine young patients for other related issues like binocular vision problems, motility disorders, refractive errors, and corneal insensitivity.
A feature of levator dystrophy, a cause of congenital ptosis, is noted in down days. The aperture on the affected side might be wider because the muscle doesn't relax properly. Management for congenital ptosis is primarily surgical, typically performed around age 3 to 5 years, allowing for accurate measurement.
But earlier if needed.
Yes. However, if the drooping lid covers the visual axis and blocks sight, surgery must be done earlier to prevent amblyopia vision loss from disuse in that eye. The choice of surgery depends on the amount of vaotosis, the levator function, and any associated conditions.
For minimal ptosis, around 1.52 millimeter, with good levator function and a noticeable lid fold, a procedure called the Fasanella Servet operation is mentioned.
This involves averting the lid and surgically removing a specific amount of conjunctiva, tarsus, and underlying mular and levator muscle tissue, then closing it with a running suture. It effectively shortens the posterior layer and lifts the lid,
For mild ptosis, where the lid lifts noticeably after instilling phenylephrine drops,
indicating Mueller's muscle is contributing.
right, then an internal conjunctival molar muscle resection is an option.
For moderate to severe otosis with moderate levator function, levator resection is the main procedure. This involves surgically shortening the levator muscle. It can be done via an incision on the inner lid surface, conjunctival approach, or through an incision on the skin, anterior approach.
The sources provide ranges for the amount of levator muscle to be resected or removed.
Yeah, noting that minimal resection for congenital ptosis is around 10 millimeters, while maximal resection for age-related ptosis might also be around 10 millimeter. Larger resections, like 18-24 millimeters, are needed for more severe ptosis with less levator function. The goal is to determine the precise amount of tissue to remove based on the measurements and function to achieve the correct lid height.
Okay.
The surgical techniques described involve incisions, careful dissection to identify and isolate the levator muscle, measuring the amount to be removed, cutting the muscle, and then reattaching the shortened muscle, or its aponeurosis, to the tarsal plate using specific sutures. Anchoring the skin to the aponeurosis is also part of creating a natural-looking lid fold.
Levator plication is presented as another option for mild to moderate ptosis with good or fair levator function.
Instead of cutting and removing muscle, the levator is folded and stitched onto itself, poplicated using mattress sutures. The sources describe it as being less time-consuming and simpler than resection with less dissection. However, disadvantages include a greater likelihood of lagophthalmos.
Lid not closing fully.
Right, and lid lag on down gaze, and it's generally not effective for severe pilosis.
When the levator muscle is present but has very poor function, 4 millimeters or less, simply shortening it isn't effective enough. In these cases, the eyelid's movement is linked to the frontalis muscle, the forehead muscle.
This is done through frontalis suspension procedures. The eyelid is connected to the frontalis muscle using various materials, including permanent sutures, strips of fascia lata,
That fibrous tissue from the thigh.
exactly, or silicone rods. Silicone rods are noted as useful for young children as a temporary measure because they are adjustable after surgery and can be removed later for a more definitive procedure once the child is older. Fascia lata slings are considered a more permanent solution and the ideal material for very poor levator action.
The source details how strips of fascia lata are harvested from the thigh and then passed under the skin of the forehead and eyelid through small incisions, finally being secured at the brow to lift the eyelid by utilizing the frontalis muscle's action.
It stresses the need for the fascia to be placed deeply and tied tightly to avoid undercorrection. The source also touches on the cosmetic aspect, mentioning creating a skin fold after surgery, if excess skin interferes with the lashes. This involves removing a horizontal strip of skin and suturing the remaining skin to the deep tissues to create a defined crease.
Okay. Moving to acquired ptosis, which typically starts later in life and is usually unilateral. Identifying the specific cause is crucial for determining the appropriate treatment.
Neurogenic ptosis is due to a problem with the nerve supply, often part of a palsy of the third cranial nerve, which supplies the levator. It can also be an isolated issue with just the branch going to the levator or related to problems higher up in the brain pathways.
And Horner syndrome.
Right. Horner syndrome is a classic neurogenic cause characterized by a mild ptosis, a small pupil, miosis, and sometimes decreased sweating on the face, anhidrosis, on the affected side, all due to interruption of the sympathetic nerve supply. Direct injury to the levator muscle or nerve from trauma is also a cause.
Treatment for neurogenic ptosis is primarily directed at the underlying cause.
Often, watchful waiting is recommended, as spontaneous recovery can occur, especially in cases like Bell's palsy affecting the facial nerve or certain types of third nerve palsies. Surgery is often deferred until any associated eye movement problems, strabismus, are corrected, as raising the lid might otherwise reveal or worsen double vision.
Crutch spectacles are mentioned.
Yes, which have a small support that props up the lid, can be used for patients with levator paralysis. The source notes that surgical results for neurogenic kyptosis are often less satisfactory compared to other types. Techniques might involve levator resection if there's some remaining function, or utilizing frontalis suspension if the levator is completely paralyzed.
Myogenic ptosis is due to a problem with the muscle itself and tends to develop gradually over years.
It can be bilateral and symmetrical in systemic muscle diseases like myotonic dystrophy or chronic progressive external ophthalmoplegia, which causes paralysis of the eye muscles, or it can be asymmetrical, as is common in myasthenia gravis.
Treatment involves managing the primary underlying disorder first. Crutch spectacles might also be an option. Myasthenia gravis is particularly highlighted as an autoimmune disorder causing generalized muscle weakness and fatigue. It's due to antibodies damaging the acetylcholine receptors at the neuromuscular junction.
Where nerve signals transmit to muscle.
Right. About 80% of patients with myasthenia gravis have circulating anti-acetylcholine receptor antibodies, and the level often correlates with the severity. Treatment aims to modify the immune system using medications like corticosteroids and immunosuppressives, or procedures like plasmapheresis or thymectomy.
A key characteristic is that the symptoms fluctuate and often improve with rest. The source notes that subptosis and difficulty with the eyes turning inwards together, failure of convergence, are often early and prominent symptoms.
And the ptosis and myasthenia.
Myasthenic PHS is almost always bilateral, though it can be asymmetrical. It notably gets worse with prolonged effort, like sustained upward gaze or trying to fixate intensely. Compensation with the frontalis muscle is usually ineffective in these cases. Weakness of the muscles that move the eyeball itself, ophthalmoplegia externa, occurs in about half of patients, but the muscles controlling the pupil are typically unaffected. Small, rapid, jerky eye movements called nystagmoid jerks can also occur.
A remarkable diagnostic test is mentioned. Temporary rapid improvement in muscle function, including the ptosis, after injecting a short-acting anticholinesterase medication like edrophonium, tensilon, or prostigmin.
These medications work by increasing the amount of acetylcholine available at the neuromuscular junction. Temporarily improving muscle function and helping to confirm the diagnosis is quite dramatic to see.
Aponeurotic ptosis is due to a problem with the levator aponeurosis, the flat tendon that connects the levator muscle to the tarsus. It often involves weakening or detachment of this tendon from the tarsus.
This is commonly caused by aging, hence often called involutional epilosis, but can also result from chronic or recurrent eyelid swelling or trauma. A key diagnostic feature is often a high upper eyelid crease or fold, combined with good levator muscle function. Sometimes, however, the fold might be absent. The source notes that the eyelid tissue itself often appears thin in these cases.
Surgery for aponeurotic ptosis involves reattaching the levator aponeurosis to the tarsus, and sometimes also an appropriate amount of levator resection.
Finally, mechanical ptosis is straightforward. The eyelid droops simply because something is weighing it down, like a tumor or significant inflammation. Treatment is directed at treating the underlying cause.
We've covered drooping eyelids, but the opposite can also happen. Lid retraction, where the lids are pulled further from the limbus than normal.
This can be caused by conditions like thyroid eye disease, where the muscles and tissues in the orbit swell, pushing the eye forward and pulling the lids back. It can also occur after a ptosis surgery if the correction is overdone or due to trauma, or be a congenital anomaly.
Treatment depends on severity.
Yes, mild to moderate retraction can be treated by weakening or removing the Muller's muscle, or surgically weakening the levator muscle. More severe retraction, over 5 millimeters, typically requires placing a spacer material, such as donor sclera, cartilage, or tissue from the inner lid, to lengthen the lid vertically.
That was an incredibly detailed look at both LAGEs and other positional anomalies. Now let's move to other significant issues: tumors and injuries.
The source covers various growths that can affect the eyelids, both benign and malignant. Benign growths include things like xanthelasma, molluscum, which we covered under inflammation warts, naivy or moles, angiomas or vascular growths, and simple cysts.
Small, clear cysts along the lashes in older individuals are often retention cysts of the mole glands, mentioned as being treatable by simply snipping off the front wall of the cyst.
Xanthelasma, or xanthema, are those slightly raised, yellowish plaques commonly seen near the inner corners of the upper and lower eyelids, often symmetrically. They are more frequent in elderly women and sometimes associated with conditions like diabetes or high cholesterol. They grow slowly and are typically treated by excision for cosmetic reasons.
A nevus, or mole, on the eyelid can be pigmented and appear on the skin or conjunctiva, often right on the lid margin. Kissing naevi are mentioned as a characteristic type, symmetrically located on the upper and lower lids that touch when the eye is closed.
Microscopic findings show nevus cells. While they can grow during puberty, malignant transformation is rare. If removed, complete excision is recommended. Hemangiomas are vascular tumors. Capillary hemangiomas appear as bright red, flat or slightly raised lesions, like port wine stains, due to dilated capillaries.
Okay.
Cavernous hemangiomas are deeper, subcutaneous swellings with larger dilated vascular spaces, often bluish, and they tend to swell when there's increased venous pressure, like when leaning over. Cavernous hemangiomas are less common in adults and may resolve spontaneously or are treated early.
These vascular growths often follow the distribution pattern of the trigeminal nerve on the face. The source also mentions the Sturge-Weber syndrome.
Right, which involves a capillary hemangioma on the face, often following the trigeminal nerve, associated with hemangiomas in the choroid of the eye, glaucoma, and abnormalities of the membranes covering the brain, which can lead to vision loss or epilepsy.
How are capillary hemangiomas treated?
Well, in children, they often decrease in size or disappear entirely by age 5-6 and can be left alone unless they are growing rapidly, causing vision loss by blocking the visual axis, amblyopia, or causing misalignment of the eyes, strabismus. Cosmetic surgery may be considered after age 3 to 5. Treatment options include localized injections of steroids, systemic steroids for large diffuse tumors given under expert guidance, or oral propranolol, which has shown promising results for periocular hemangiomas.
Other options.
Superficial radiotherapy is also mentioned within specific dose limits, but injecting sclerosing solutions into the lesion is discouraged due to the risk of scarring.
Neurofibromatosis, also known by names like plexiform neuroma or von Recklinghausen disease, can affect the eyelids and orbit, often creating a characteristic appearance with thickened, overgrown tissue, particularly in the temporal region.
The hypertrophied nerves can be felt as hard cords or nodules under the skin. The condition involves overgrowth of the connective tissue surrounding the nerves. It can also affect the nerves within the eye, sometimes associated with tumors of the optic nerve or an enlarged eye, ophthalmos. The source notes that surgical results for cosmetic improvement are often unsatisfactory.
Now the more serious category, malignant tumors. Carcinomata are the most common types in the eyelids, followed by rarer sarcomata and malignant melanomata.
The sources state that any gland in the eyelid can potentially become carcinomatous, though this is rare. Basal cell carcinoma, often called a rodent ulcer, is highlighted as the most frequent malignant epithelial tumor in fair-skinned individuals.
Where does it usually appear?
It has a predilection for the lower eyelid, especially near the inner corner. It typically starts as a small, pearly pimple that slowly enlarges and ulcerates, developing characteristic raised, rolled, and firm edges. It's locally malignant, meaning it spreads slowly but deeply, destroying surrounding structures and invading the lids, orbit, and even bone. It arises from the accessory epithelial structures. It's uncommon before age 40, and its growth is measured in years, not weeks or months.
Squamous cell carcinomata are less common in the eyelids and tend to occur at the transition zones, like the lid margins, more frequently in the elderly.
And unlike basal cell, squamous cell carcinoma can spread to nearby lymph nodes, such as the preauricular and submaxillary nodes. Sebaceous cell carcinomata are particularly insidious and often affect the upper eyelid. They can present as a hard nodule or, deceptively, as recurrent chalasia that don't resolve. They are more common in females and in Asian populations. High suspicion for this malignancy is needed in elderly patients with unilateral blepharitis or chalasia that keep coming back. It's locally invasive and carries a poorer prognosis if it spreads into the orbit.
Kaposi sarcoma is mentioned.
As being seen frequently in the eyelids of patients with AIDS, sarcomas in general are rare and can affect the orbit and lid symmetrically, causing the eye to bulge forward, proptosis. Some types can be associated with blood disorders like leukemia. They typically have a slow but continuous growth pattern and can endanger the eyes by preventing full lid closure. Malignant melanomata are rare in the eyelids, though melanosis, a generalized brown pigmentation that develops in adulthood, can occasionally transform into cancer.
Treatment for malignant eyelid tumors is primarily surgical.
Local resection with clear margins is the goal. The source suggests a margin of 3-5 millimeters around the visible tumor, and ideally using frozen section analysis during surgery to ensure all tumor cells have been removed. For tumors that are too extensive to be removed surgically while preserving the eye, or those that have spread into the orbit, Exenteration.
Removal of the eye socket contents.
Yes, surgical removal of all contents of the eye socket, including the eyeball, muscles, and fat, is often necessary, sometimes followed by radiotherapy. If the tumor involves the fornix, the muscle that moves the eye, or the sclera, exenteration is also indicated.
What if surgery isn't possible or desired?
Large or recurrent tumors that can't be removed surgically without sacrificing an eye that still has useful vision might be treated with chemotherapy or radiotherapy, provided there is no bone involvement. However, the source includes a caution about radiation therapy. It can sometimes lead to a firm surface scar that masks underlying tumor spread, making careful monitoring for recurrence essential.
Mohs micrographic surgery is specifically mentioned.
As a technique that allows for precise removal by microscopically examining tissue layers during the procedure, ensuring complete tumor removal while minimizing the amount of healthy tissue removed. It's very effective for certain types, especially basal cell.
Moving on to injuries, the common types affecting the eyelids are contusions, wounds, and burns. Treatment follows general surgical principles, but it's always critical to assess for associated injuries to the deeper orbit or the eyeball itself.
Contusions, like a black eye, can look quite alarming with swelling and bruising, but are often less severe than they appear. However, the prognosis should still be guarded initially until the full extent of any underlying injury is clear. Treatment is conservative with cold compresses initially.
For wounds, the direction relative to the natural skin lines matters significantly.
Yes, surgical incisions that follow the lines of the orbicularis fibers tend to gape minimally and heal well. Vertical wounds, however, gape significantly and can result in disfiguring scars, potentially causing ectropion or distortion, especially if they adhere to the underlying bone. The most problematic are vertical, full-thickness lacerations that cut through all layers of the eyelid.
Because they can cause a notch.
Exactly. If these aren't repaired properly by primary union, they can result in a permanent notch in the lid margin, a traumatic coloboma, significant disfigurement, inability to close the lid fully, and persistent tearing. Treatment for wounds involves thorough cleansing and careful suturing. Minimal tissue excision is usually needed due to the eyelid's rich blood supply. Tetanus toxoid administration is important.
Dog bites.
For dog bites in children's eyelids, anti-rabies prophylaxis is necessary. Lacerated wounds may require plastic surgical techniques to minimize scarring and deformity. If a vertical wound has cut through the canaliculates that tear drainage channel, it requires special care to repair it meticulously, often by suturing it over a small silicone tube to keep it open during healing. Failure to repair a lid margin wound properly will result in a lid coloboma. This can be repaired surgically, ideally by direct closure, if the defect is relatively small, less than 1/3 of the lid length.
Burns to the eyelids require diagnosis of their depth.
First-degree burns involve only the surface and are treated with cleansing and soothing applications. Second-degree wounds involve deeper layers, vesicles are open, dead epithelium removed, and similar treatment applied. Third-degree burns are full thickness, destroying all layers. These require immediate cleansing and coverage, ideally with full-thickness or split-thickness skin grafts, combined with a temporary tarsorrhaphy to ensure the eye is covered until the risk of scar contraction pulling the lid away has passed.
The major danger from severe lid burns is
severe exposure keratitis leading to vision loss. The source warns against using coagulating agents like tannic acid. The best way to prevent devastating scarring and ectropion is prompt skin grafting before scar tissue has a chance to form. If scarring does occur, plastic surgery is needed later to correct the deformity.
That brings us to our final section, looking at conditions that are present from birth or appear with advancing age.
Yes, some of the positional anomalies we discussed earlier, like symbolferrin, ankylobalferrin, ectropion, entropion, and trichiasis, can sometimes be congenital malformations. And as we've seen, ptosis is a relatively common congenital defect,
Dysarchiasis is mentioned as a rare congenital condition.
where an extra row of eyelashes grows from an abnormal location, often where the meibomian glands should be, sometimes affecting all 4 lids. These extra lashes can irritate the cornea. Management involves splitting the lid margin and using cryotherapy or other methods to destroy the abnormal follicles.
Coloboma of the lid is a congenital notch or defect in the eyelid edge.
Most commonly on the inner side of the upper lid, though it can be multiple. It might be associated with other findings like a skin bridge connecting the lid to the eyeball, or a dermoid cyst at the edge of the cornea. Other congenital abnormalities elsewhere in the body are often present. Causes include incomplete closure of embryonic facial clefts or constriction by amniotic bands during development. A notch in the outer lower lid is sometimes associated with specific syndromes like Mandibulofacial dysostosis or Goldenhar syndrome.
Cryptophthalmos is very rare.
Very rare, yes. The skin is continuous from the brow over the eye to the cheek without a visible eyelid opening. It's associated with severe abnormalities of the eye and orbit underneath. Microbulfarin or ablepharin refers to abnormally small or completely absent eyelids, usually found alongside microphthalmos, meaning a small underdeveloped eye.
Microphthalmos can be linked to cysts.
Yes, it can be associated with a congenital cyst swelling the lower lid, connected to the globe and containing retinal tissue, thought to be due to a defect in embryonic fissure closure. Even if the eyeball appears absent clinically, in ophthalmos, the source notes that microscopic vestiges are always present.
Epicanthus is a semilunar skin fold that covers the inner corner of the eye, the inner canthus.
It's usually bilateral and gives the appearance of widely spaced eyes or even a convergent squint, particularly in individuals with a flat nose bridge. It often decreases or disappears as the nose develops with age. It's a normal feature in Mongolian populations. If it persists and is considered a deformity, it can be corrected with plastic surgery.
And finally, age-related changes. The eyelids are often among the first areas to show signs of aging.
Yes, like wrinkles, larger skin folds, and that characteristic fullness or bags under the eyes. Symmetrical soft swellings above the inner corner in the elderly are often due to orbital fat prolapsing or pushing forward through weakened areas in the orbital septum.
Dermatochalasis.
Specifically refers to the presence of loose, redundant skin and muscle in the eyelids due to weakening of the connective and elastic tissue with age. Blepharoplasty is the surgical procedure performed to address these age-related changes. It involves removing excess skin and often excess fat through incisions typically placed discreetly in the upper eyelid crease and just below the lower eyelashes.
This surgery corrects drooping of the skin, removes the bags under the eyes, and smooths and tightens the remaining skin. The incisions are planned to fall within natural skin contours, making the resulting scars barely visible.
The source also mentions using lasers for blepharoplasty. A CO2 laser can be used for relatively bloodless incisions and for dissecting and removing fat. An erbium.YAG laser can be used for resurfacing the skin, particularly on the lower lids, to stimulate collagen production and achieve a tightening and smoothing effect.
Wow, we truly did a deep dive there, moving from the microscopic layers of anatomy all the way through a vast spectrum of conditions: inflammation, infections, chronic diseases, positional issues, birth defects, trauma, tumors, and the effects of aging. It's quite a list.
And it all connects back to that initial look at the anatomy, doesn't it?
Mm.
Understanding the structure of the tarsus, the specific glands, the different muscles, and how they're anchored and innervated, that knowledge is the key to understanding why blepharitis leads to certain sequelae, why different types of ectropion or entropion require specific surgical approaches, or why a recurrent chalation needs a biopsy.
We aim to extract and highlight the key nuggets of knowledge, the clinical significance, and the surprising details from the sources you provided. Everything from the vital importance of a sharp lid margin for tear film, to the cascade of problems starting with chronic blepharitis, to the complex surgical repairs for misplaced lids or ptosis, and the need to consider malignancy and unusual-looking growths. It's all here.
And recognizing that even seemingly minor issues, like a small skin lesion or chronic dryness, can have significant consequences for vision if the underlying cause and anatomy aren't properly understood and addressed. It really drives home the detail needed for mastery in this area.
So, thinking about the intricate anatomy, the vital functions they perform, and the incredible range of things that can impact them, does learning all this change how you think about something as simple as blinking or tearing up? What might seem like a mundane part of your body is actually a fascinating, complex system working tirelessly to protect your sight.
It certainly makes you appreciate the complexity and seemingly simple actions. There's always so much more going on than meets the eye, especially, well, with the eye itself and its protectors. Really makes you think.